What if I told you that in virtually every single hand you operate on, there's this complex hidden electrical grid that your standard anatomy textbooks barely even mention?
Yeah, it's honestly something that catches a lot of surgeons off guard.
Right. Well, welcome to the deep dive. If you are prepping for your FRCS plastic surgery board exams right now, you are in the exact right place. We're skipping the fluff today.
Absolutely, no time to waste.
The mission for this deep dive is a rapid-fire, high-yield review of the anatomy and the pathophysiology of ulnar nerve compression. And before we get into the weeds, take a second right now to press follow on the show so you don't miss any of our future revision deep dives.
Yeah, and if you want to definitively lock down your prep, you should get a premium subscription right now that gives you exclusive access to all of our journal club and clinical cases deep dives.
Exactly. So let's unpack this. We need to start at the literal beginning. Where does the ulnar nerve actually originate before it starts causing us, all these clinical headaches?
Right. Well, it is the absolute necessary starting point for the boards. You have to know the baseline wiring before you can troubleshoot the system, right? So the ulnar nerve arises from the medial cord of the brachial plexus.
Okay, medial cord.
Yeah. Structurally, it primarily contains nerve fibers originating from spinal roots C8 and T1. But, and this is a very common exam pearl, you have to remember that you'll occasionally see fibers from C7 contributing to the mix as well.
Okay, so we have C8, T1, and like the occasional C7 coming off the medial cord. Our goal today is to trace this nerve all the way down the arm, hitting the two major exam favorite compression sites.
Right, the elbow and the wrist.
Exactly. First, we tackle the elbow, and then we're going to travel distally down to the wrist. So let's start with the elbow, specifically cubital tunnel syndrome. I mean, this is the second most common upper limb compression neuropathy, right behind carpal tunnel.
Oh, without a doubt. It's incredibly common.
So can you build this tunnel for us in like three-dimensional space?
Sure. Think of it as a highly confined architectural space that the nerve is just forced to navigate. The walls of this tunnel are entirely bony. You have the medial epicondyle of the humerus on one side and the olecranon on the other.
Okay, so bone on the sides. What about the floor?
The floor is it's fibrous and capsular. It's made up of the elbow joint capsule itself and the medial collateral ligament.
Got it. Capsule and ligament on the bottom. What is covering the top?
Well, the roof is why things get clinically vital. It's formed by the deep fascia of the flexor carpi ulnaris, the FCU, and a specific structure called the arcuate ligament of Osborn.
Osborn's ligament, right?
Yeah, Osborn described these transverse fascial fibers spanning directly between the medial epicondyle and the olecranon. And this roof is entirely contiguous with the aponeurosis that sits between the two heads of the FCU.
This is where I think the anatomy becomes incredibly intuitive if you look at it physically. I mean, it is not just a static bony tunnel. It's highly dynamic.
Oh, completely. It changes constantly.
Right? I always visualize it like bending a pliable, thick-walled pipe, like a heavy garden hose. When you flex your elbow, you aren't just stretching the nerve over a joint hinge, You are physically changing the geometry of the tunnel itself.
That's a great way to picture it.
You're taking a space that is perfectly round when the arm is straight, and you are aggressively squashing it into an oval shape as the elbow flexes.
That is the exact biomechanical reality, and it beautifully explains the pathophysiology we see in these patients. When that tunnel shape shifts from round to oval during elbow flexion, two major physical changes occur to the ulnar nerve.
Okay, what's the first one?
First, the nerve itself is forced to elongate by about 5 to 8 millimeters. It physically stretches.
Wow, up to 8 millimeters.
Yeah. But second, and this is far more critical to the disease process, that geometric shape change increases the interneural pressure up to 6 times its normal resting rate.
Wait, really? 6 times the internal pressure just from bending your arm?
Just from bending it, yeah.
Let's connect this to the actual pathophysiology then. How does that physical pressure translate into nerve damage?
Well, it all comes down to blood flow. That massive spike in intraneural pressure eventually exceeds the venous capillary pressure within the nerve. That halts venous return, which leads to localized edema, which in turn chokes off the arterial supply to the nerve itself.
So it's literally starving the nerve of oxygen.
Exactly. It creates microvascular ischemia of the vasa nervum, the tiny blood vessels supplying the nerve. And that ischemic pain is the primary driver behind a patient's nocturnal symptoms.
Oh, right, because of how people sleep.
Right. Think about it. Most people sleep in a fetal position with their elbows acutely flexed for 6 to 8 hours. They are essentially strangling the blood supply to the nerve all night long.
That makes the clinical complaint of night pain completely logical. Now, if we look beyond just sleeping positions, there are 7 classic anatomical structures or conditions that cause compression at the elbow.
Yeah, the FRCS exams absolutely love this list.
So let's group them logically so they're easier to remember. Let's start with the fascial bands. The one that always comes up first is the arcade of Struthers. Wait, I need to pause you here and push back on this because this is a notorious trap.
Oh, the phrasing trap. Definitely.
Clarify the absolute difference between the arcade of Struthers and the ligament of Struthers, because the examiners will try to trip you up on that.
They absolutely will. I mean, they sound nearly identical, but they belong to completely different nerves in completely different locations. The arcade of Struthers is a fascial band running from the medial intermuscular septum to the medial head of the triceps.
And that's the one for the ulnar nerve.
Correct. It sits about 8 centimeters proximal to the medial epicondyle. This is your ulnar nerve compressor. The ligament Struthers, on the other hand, is a completely distinct structure. It's often associated with the supracondylar process, and that compresses the median nerve.
Okay, so the arcade is ulnar, the ligament is median. Write that down. If you mix those up in an oral exam, it is a very hard hole to dig yourself out of.
It really is. It's a classic rookie mistake.
Okay, sticking with the structures around the tunnel, what about muscular causes of compression?
You have 2 major muscular culprits. First is hypertrophy of the medial head of the triceps. If that muscle bulk increases, it encroaches directly on the proximal entry point of the cubital tunnel.
And the second one?
The other is an anomalous muscle called the inconius epitrochlearis. This is an accessory muscle present in a small percentage of the population. It sits directly over the ulnar nerve at the elbow, essentially replacing Osborne's ligament with contractile muscle tissue.
So it physically squeezes the nerve every time it fires.
Exactly.
And then we have the roof of the tunnel itself, which we touched on earlier. The aponeurosis between the 2 heads of the FCU can thicken and become a rigid constrictor. So that's our fascial and muscular causes. What about bony alignment issues?
The primary bony issue is cubitus valgus. That's an exaggerated lateral deviation of the elbow joint. The timeline here is fascinating, actually.
How so?
Well, you will often see a patient present with this in their 50s or 60s, but the root cause was actually a distal humerus fracture they sustained when they were a child. The bone healed with this valgus deformity.
Oh, I see. So because the elbow is angled outward.
Right. The ulnar nerve, which is sitting on the inside of the elbow, has to travel a much longer physical distance. Over decades, this creates chronic traction and friction. This specific scenario is famously known as tardy ulnar nerve palsy due to the massive delay between the injury and the onset of symptoms.
Tardy ulnar nerve palsy. It's essentially a slow-motion traction injury. We also have dynamic instability. The nerve can physically dislocate, right?
Yes, recurrent dislocation of the nerve over the medial epicondyle. In some patients, the fascial restraints are loose, and every single time they flex their elbow, the nerve violently snaps back and forth over the bony prominence.
That sounds painful.
It is. This recurrent direct mechanical trauma produces a severe friction neuritis.
And the final category would just be your classic space-occupying lesions. Anything taking up physical real estate in a tunnel that already has 0 spare room. So we're looking at lipomas, ganglia from the elbow joint, or osteophytes from arthritis.
Exactly. Anything that crowds the space.
So we've outlined the mechanics and the anatomical traps. Let's move into the clinical presentation. When a patient sits across from you in clinic, what is the symptomatic progression of all this pressure and friction?
Early on, it is surprisingly vague. The patient will complain of ill-defined aching pain in the upper limb, often radiating up the medial arm or down the forearm.
But the sensory changes eventually show up, right?
They do. The hallmark sensory changes will appear as paresthesia and numbness strictly localized to the ulnar 1.5 fingers, meaning the entirety of the little finger and the ulnar half of the ring finger.
And clinically, you can often provoke this right in the room.
Yeah.
If you just have the patient fully flex their elbow for about a minute and it reproduces that pain and tingling, that is considered a highly sensitive diagnostic test.
Right, the elbow flexion test.
But the exams are going to push you on the motor deficits. We have 3 classic eponymous signs: Frohman's, Wartenberg's, and Pitcher's Testod. Let's break down the exact biomechanics of these, because you cannot just memorize the names.
No, you really have to understand the muscle battles happening in the hand.
Let's start with Frohman's sign. My understanding is that this is essentially a substitution trick the body plays when a key pinch muscle fails.
That is exactly right. You test for Froment's sign by asking the patient to aggressively hold a piece of paper between their thumb and index finger while you try to pull it away.
Okay, so a lateral pinch.
Yeah. Normally, the adductor pollicis muscle, which is supplied by the ulnar nerve, keeps the thumb flat and powerfully adducted against the index finger. But in profound ulnar compression, that adductor is paralyzed.
So to keep the paper from slipping.
The brain recruits a substitute muscle, the flexor pollicis longus, which is innervated by the median nerve.
Ah, so instead of a flat thumb holding the paper, the median nerve fires, and the interphalangeal joint of the thumb acutely flexes and pinches down like a hook.
Precisely. That pronounced compensatory IP joint flexion is a positive Froment sign.
Okay, let's look at Wartenberg's sign. This is the one where the little finger spontaneously drifts away from the hand. What is the specific imbalance happening there?
Wartenberg's sign is the inability to adduct the extended little finger. If you ask the patient to hold their hand out straight with their fingers together, their little finger will just remain abducted, sticking out to the side.
Why does it do that?
The mechanism here is a battle of unopposed action. The extensor digiti minimi, or EDM, which is powered by the radial nerve, naturally pulls the finger out and back. Normally, the third palmar interosseous muscle and ulnar innervated intrinsic fights the EDM and pulls the finger back in.
So the ulnar nerve is offline, the intrinsic muscle fails, and the radial nerve essentially hijacks the posture of the little finger because there are no brakes left.
Exactly. It's a postural deformity driven by unopposed radial nerve action.
And the third one, the Pitras tacet sign.
This tests the dorsal interossae. You have the patient place their hand completely flat on a tabletop. A positive Pitras tacet sign is the patient's absolute inability to abduct their middle finger from side to side while the hand remains flat on the board.
Because the ulnar innervated dorsal interossae are completely responsible for that specific movement.
Right. If they can't wag that middle finger, it's a positive sign.
Let me bring up a paradox that I've seen trip up residents constantly. If we look at the gross anatomy, the ulnar nerve innervates the FCU and the ulnar half of the flexor digitorum profundus, the FDP.
Correct.
The branches to those muscles come off in the proximal forearm, which is entirely distal to the cubital tunnel. So physically, those nerve fibers have to travel right through the compression site at the elbow. Why then do we so rarely see weakness in the FCU and the FDP in standard cubital tunnel syndrome?
That is a phenomenal question, and understanding why answers one of the trickiest board questions you can face. It all comes down to the topographic arrangement of the fascicles inside the nerve itself.
Meaning how the wires are bundled?
Exactly. The nerve is not just a random bundle of wires. The nerve fibers destined for the FCU and the FDP are located deep within the center of the ulnar nerve bundle as it passes through the elbow.
Okay, so they're very deep.
Yeah. And the fibers destined for the intrinsic muscles of the hand are located peripherally on the outside of the bundle.
So the intrinsic hand fibers are acting like a bumper guard.
That's it, exactly. The compressive forces at the elbow hit the outside of the nerve first. So the hand intrinsics take the brunt of the damage, while the deeply buried FCU fibers are structurally protected.
That makes total sense.
Right. So if an exam vignette presents a patient with profound, isolated FCU weakness, you need to be highly suspicious of a laceration, a tumor within the nerve, or a lesion much higher up in the brachial plexus, rather than a standard mechanical compression at the cubital tunnel.
That topographic explanation is brilliant. Okay, let's briefly touch on treatment pathways before we move down the arm. If they fail conservative splintage, which we do at less than 90 degrees to physically stop that tunnel from becoming an oval, what are the surgical options?
Well, the surgical approach is heavily debated, which means you need to know the options for the exam. You can perform a simple in situ decompression where you just release Osborne's ligament in the fascial roof.
Or you can move the nerve, right?
Yeah. You can perform an anterior transposition, physically moving the nerve out of the tunnel and placing it anterior to the elbow axis, either subcutaneously or deep beneath the flexor pronator mass. You can also do a medial epicondylectomy, simply shaving off the bony wall.
Now, what's the universal surgical rule for all of these?
No matter the approach, meticulous care must be taken to identify and preserve the medial cutaneous nerves of the forearm during your skin incision and exposure.
Because if you cut those,
it leads to a devastating, painful neuroma right over the elbow that is often way worse than the original compression.
Wow. So we have conquered the elbow. Let's pivot. Imagine a clinical scenario. A patient aces all your elbow tests. Tunnels at the cubital tunnel is negative. Elbow flexion produces zero pain. But their hand exhibits profound ulnar motor weakness. The intrinsic muscles are wasting away. Where do we look next?
We travel distally to the wrist. We have to examine Goyen's canal.
Okay, Goyen's canal.
It's a much rarer site for ulnar nerve entrapment compared to the elbow, but it is an absolute goldmine for exam questions because the anatomy dictates perfectly localizable symptoms. Goyen's canal is a triangular space situated superficial to the flexor retinaculum.
Define the exact boundaries for us. This is where the textbooks get dense, so let's make it really clear.
It's a short tunnel. It runs from the proximal edge of the transverse carpal ligament down to the fibrous arch of the hypothenar muscle origin. The floor is consistently formed by the pisohamate ligament, and the roof is formed by the volar carpal ligament.
Right. And we must note the vasculature here. The ulnar artery traverses this canal right alongside the nerve. The key anatomical relationship to memorize is that the artery always sits radial to the ulnar nerve.
Yes, absolutely crucial.
Okay, so within this very short canal, the ulnar nerve bifurcates. It divides into a deep branch and a superficial branch. Because of this split, anatomists divide Goyen's canal into 3 distinct zones. These zones are the ultimate diagnostic key for the boards. Walk us through how a lesion in each zone presents.
Sure. Zone 1 is the most proximal section, located before the nerve bifurcates. If a patient has a compression here, the entire trunk is affected. They will present with a mixed deficit, both profound motor weakness in the hand and sensory numbness in the ulnar digits.
That's the easiest one to grasp. What happens when we move distally into Zone 2?
Zone 2 involves only the deep motor branch as it curls around the hook of the hamate. Compression here results in pure motor loss. The patient will have zero numbness.
No numbness at all.
None. But remember, that deep branch is the workhorse of the hand. It supplies the hypothenar muscles, all the interossei, the 2 ulnar lumbricals, and the adductor pollicis.
So a Zone 2 lesion gives you a devastatingly weak, clumsy hand. You'll see the classic ulnar claw hyperextension at the MCP joints and flexion at the IP joints of the little and ring fingers.
Exactly. Plus all those positive eponymous signs we discussed, but they will have totally normal feeling in their fingertips.
That is such a distinct clinical picture. Finally, Zone 3 involves only the superficial branch.
Right. A lesion here causes pure sensory changes. This branch supplies a tiny muscle called the palmaris brevis, but its main job is providing sensation to the ulnar 1.5 digits. The patient's motor function will be completely intact, but their little finger will be entirely numb.
So at the elbow, we had dynamic stretching and fascial bands causing the compression. What are the specific hazards inside Goyen's canal?
Down at the wrist, we see entirely different mechanisms. Acute trauma is a major factor, specifically fractures to the hook of the hamate. You see this in golfers or baseball players who ground their club bat violently, driving the grip into the base of their palm.
And then you have repetitive vascular trauma, famously known as hypothenar hammer syndrome. Explain the mechanics of that.
You see this in mechanics or carpenters who literally use the base of their palm as a hammer to strike tools or hubcaps.
Ouch.
Yeah, the repeated blunt force trauma crushes the ulnar artery against the hook of the hamate. The artery can thrombose or form an aneurysm, and that vascular swelling then physically compresses the adjacent ulnar nerve inside Zone 1 or 2.
That is a brutal mechanism of injury. Other causes would include your space-occupying lesions again, ganglia are very common here, and anomalous muscle bellies like an accessory palmaris longus inserting into the canal.
Yep, ganglia are huge culprits there.
Now, here is a critical clinical question. Without waiting weeks for nerve conduction studies, how do you confidently differentiate a wrist compression from an elbow compression just by examining the patient's hand?
Oh, the clinical giveaway, the absolute silver bullet on a physical exam, is testing the dorsal cutaneous branch of the ulnar nerve.
The dorsal branch.
Yes. This branch provides sensation to the back of the hand, specifically the dorsal ulnar aspect. The key is its origin. This branch comes off the main ulnar nerve trunk several centimeters proximal to the wrist joint. It branches off well before the nerve ever enters Goyen's canal.
So it bypasses the wrist tunnel entirely.
Exactly. Therefore, if the compression is localized inside Goyen's canal, sensation on the back of the hand will be perfectly preserved. But if the patient has a high lesion up at the cubital tunnel, that dorsal sensation will very likely be lost.
Trace the wiring, find the deficit. It is beautiful logical anatomy, but the board examiners know that textbook anatomy only gets you so far, you know.
Oh, they love to test the exceptions.
They absolutely love to throw a wrench in the works with paradoxical presentations where the clinical findings completely contradict the established anatomical rules. Let's spend our final few minutes exploring the rule breakers.
We are talking about the communicating branches. These are variable connections that exist between the median and ulnar nerves. They completely defy standard mapping and create paradoxical patterns of motor and sensory disturbance.
Before we list them, let's address the semantic debate in the literature because language really matters on these exams. Textbooks heavily use the term anastomosis for these neural connections.
Right, which isn't exactly accurate.
Exactly. Anatomically, as some purists will eagerly point out, anastomosis is a vascular term requiring a stoma, or an opening between vessels. Nerves don't have openings. Their fibers just cross over and join adjacent sheaths. So communication is the accurate physiological term, but anastomosis remains the prevailing historical language.
You definitely have to recognize both terms.
Let's start with the forearm connections. Explain the Martin-Gruber anastomosis.
The Martin-Gruber communication occurs in the forearm, where motor fibers from the median nerve physically cross over to join the ulnar nerve trunk. Clinically, this creates a fascinating scenario. Let's say a patient with this anatomical variant suffers a severe low median nerve laceration at the wrist. You evaluate them, expecting to see paralysis of the median innervated the ulnar muscles. But you are baffled to find that their thumb function is completely normal.
Oh, wait. How is that possible if the median nerve is cut?
Because the motor fibers destined for those ulnar muscles never crossed the wrist inside the median nerve. They took a detour, they crossed over in the forearm via the Martin-Gruber branch, rode the ulnar nerve safely down through Guyon's canal, and then innervated the thumb.
It's essentially like having a backup generator perfectly wired into the adjacent circuit. And this is not some 1 in a million rarity. Studies report that Martin-Gruber anastomosis occurs in anywhere from 5 to 40% of people. What about the reverse scenario in the forearm?
That is the Marinacci communication. This is a connection from the ulnar nerve crossing over to the median nerve in the forearm.
Is that as common?
No, it's less common, seen in roughly 1 to 17% of people. If someone has a Marinacci connection, a high median nerve injury near the elbow might not produce the expected catastrophic hand paralysis because the distal median nerve is being supplied with active motor fibers crossing over from the healthy ulnar nerve below the injury site.
Okay, so Martin-Gruber and Marinacci are your forearm crossovers. Now let's look at the connections happening inside the hand itself. First is the Reich-Canu anastomosis.
Reich-Canu is an ulnar to median connection deep within the palm. Specifically, motor fibers cross from the deep motor branch of the ulnar nerve into the recurrent motor branch of the median nerve.
What's the clinical effect of that?
Well, because of this link, the ulnar nerve may end up supplying some, or even all, of the ulnar muscles that are normally strictly median innervated, and this is staggeringly common. Cadaveric studies report it occurs in up to 83% of hands.
83%. When the variant occurs in over 80% of the population, the standard textbook anatomy is practically the exception rather than the rule. And finally, the fourth rule breaker. This is the one that keeps hand surgeons awake at night. The Berrettini branch.
The Berrettini branch is a superficial palmar communication between the ulnar and median nerves. Crucially, unlike the other three we just discussed, this is a purely sensory connection. It sits horizontally right at the distal edge of the transverse carpal ligament.
Which puts it precisely in the surgical crosshairs of one of the most common operations in the world.
Exactly. Because it drapes right across the exit of the carpal tunnel, it is the structure at highest risk during an endoscopic carpal tunnel decompression. If the surgeon isn't looking for it and blindly divides that transverse ligament, they will cleanly sever the Berrettini branch.
And what happens to the patient?
The patient will wake up with an unexpected permanent numb spot in the third web space of their hand. And here's the profound reality. This sensory branch is reported to be present in up to 100% of individuals.
Up to 100%. Wow. It forces a complete perspective shift on how you approach surgery.
It absolutely does. I want you to really consider how that nearly 100% prevalence of the Berrettini branch completely reframes the concept of a routine endoscopic carpal tunnel release. It forces you to realize that standard anatomical text plot diagrams are often just mere suggestions of what you will actually encounter.
Right.
When you pick up a scalpel, you have to operate with the baseline assumption that every single patient's hand might be quietly harboring a complex, undocumented electrical grid.
That is a brilliant final thought to carry with you into the operating room and into your board exams. Question the textbooks, trace the wiring, and never assume the anatomy is simple. If you learned something valuable today that clarifies your FRCS revision, please take a second to rate the show. It really helps us keep producing these deep dives.
Yeah, and leave a comment or a question down below telling us exactly what complex plastic surgery topic you want us to demystify next.
Until next time, keep studying, keep challenging the standard answers, and we will see you on the next deep dive.